of the sound. So many things which will happen at the level of brainstem, and then once the signal reaches to the auditory cortex assigns a meaning to the sound which is reaching to the auditory cortex basically. So it is doing the work of an interpreter. It interprets what is coming to the auditory cortical system.
Sujit, sorry to disturb you. Can you just maximize your screen? It's
Yeah,
like
I have
we can
maximized
see
this.
your notes also side by.
Okay, just 1 second.
So this full screen.
No, it is in the full screen only. Just 1 second.
Okay. You can, yeah, you can, yeah, do that. Yeah, it's better. Yeah, it's fine now.
Yeah,
Yeah, it's fine. Yeah, thanks, man.
yeah, okay. So next thing which you have to understand is the central auditory nervous system. It is very important for you to understand the central auditory nervous system. Now, this is the thing which you have learned till date, that we have the cochlea in the inner ear, and then we have next station is the cochlear nucleus, and then we have superior olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and the auditory cortex. This pathway we also know as CNS limca. CNS stands for cochlear nucleus, S stands for SOC, L stands for lateral lemniscus, I stands for inferior colliculus, then M stands for medial geniculate body, and then auditory cortex. So it is also called as CNS LI limb CA, CNS limca. So easiest way to remember this whole pathway is CNS limca. Now this is the easiest pathway which you have learned, but when you look at the entire auditory pathway, these are the afferent connections. These are the afferent connections in the sense that the right cochlea nucleus is connected to the SOC via ipsilateral pathways, also the contralateral pathways. The cochlear nucleus is also giving Cochlear nucleus is also giving input to the inferior colliculus. Then you have SOC wherein it is giving the ipsilateral connection to the lateral lemniscus. Then it is giving a contralateral connection to the lateral lemniscus. You also have connection from here to inferior colliculus. So you have multiple number of connections which you can see that from here, from the cochlear nucleus till the medial geniculate body. But this is one part of the system which you are seeing. Now you have connections like this. Now you see that there are many, not only the afferent connections, there are many efferent connections which are connected from the auditory cortical system to the different levels. You can see that from the auditory cortical system you have a connection to the medial geniculate body. From the auditory cortex you also have a connection to inferior colliculus. From here you have another efferent pathway which is coming to the superior olivary complex, another efferent pathway which is also coming to the cochlear nucleus. Also you have SOC. From SOC you have a pathway which is coming to the contralateral cochlea, and from this side it is coming to the contralateral cochlea on this side. So if you look at the entire central auditory nervous system, which starts from the cochlear nucleus to the auditory cortex, the entire pathway appears to be like this. So you have afferent connections, you have efferent connections. You can see the different connections which you can see in this diagram. So basically what I mean to say is that the entire auditory system is very complex. The only thing which is good about the auditory system, the central auditory nervous system, is that you have the designated nuclei, something like the signal from the cochlea will go to the cochlear nucleus only. From the cochlear nucleus it goes to the SOC, lateral lemniscus, inferior colliculus, medial geniculate body, or the auditory cortex. It doesn't go like from the auditory system there is a connection to the eyes, or there is a connection to the spinal cord, or there is a connection to the lower limb or the upper limb. Okay, it doesn't go anywhere. There are certain designated nuclei where these connections are there. So what happens is that whether there is a problem at the level of cochlea, or at the level of auditory nerve or cochlear nucleus, or whether it is there at auditory cortex, it leads to only one of the hearing related deficits. So you can call this deficit as sensory neural hearing loss. You can call this deficits as central auditory pathway. You can call these deficits as the cortical deafness, whatever you want, but it is leading to only one of the hearing related deficits. Now, what is important is this is what you have to understand when you are looking at the auditory nervous system. Now, this is a typical neuron. So you have the cell body of the neuron. So basically, when you look at the cell body of the neuron, you have to understand that cell body is the powerhouse of this neuron. Okay, and these are the dendrites. These are the dendrites. Their dendrites are responsible for receiving the input from the peripheral receptors or from another neurons, and then you have the axon are primarily responsible for carrying the signal which is coming from the peripheral receptor or coming from the another neuron and give it to another set of neuron via the terminal button here, which you can see here. Now another thing which you can see here, it's this, the one in yellow color, which is called as myelin sheath, or you can see in this neuron, these are called as myelin sheath. Myelin sheath is responsible for faster conduction of the action potential. I'm going to discuss this when the myelin disappears, what is going to happen at the later point of time. So this is responsible for faster conduction of the action potential. Now, the neurons are of different types. A structural classification, if you look into, you have bipolar neurons, you have pseudo unipolar neurons, and you have multipolar neurons. What you have to understand is, as you go higher up, that means to say that at the central auditory nervous system, you have all multipolar neurons, whereas the auditory neurons are typically a bipolar neurons. Remember this. Auditory neurons are typically a bipolar neurons, whereas the neurons which are located at cochlea nucleus, SOC, lateral lemniscus, or auditory cortex, they are all are a multipolar neuron. There are some variations in the size and the shape of the cell body at different levels, but basically they all are your multipolar neurons. Okay. Now, unipolar neurons which are there, they are typically there in sensory neurons with receptors which are located within the skin, the joints, the muscles, and the internal organs. Whereas all the bipolar neurons are often sensory neurons which are associated typically with the visual system and the auditory system. Okay, the two special senses have your bipolar neurons. There are another way of classifying these neurons, that are afferent neurons, efferent neurons, and your interneurons. Afferent neurons means the work of the afferent neuron is to carry the signal from the peripheral system to the central system. Such as, for example, the auditory nerve carries the signal from the inner hair cell to the cochlear nucleus. So this is an afferent neuron. Efferent neurons which are connected between the higher structure to the lower structure. Now you would have studied that there is an efferent pathway which starts from the superior olivary complex and which is supplied to the contralateral outer hair cells. So these are your efferent pathways. So starting from higher up and coming to the lower system. Interneurons are the one wherein it is connecting one hemisphere to the another hemisphere, or in the same hemisphere it is connecting one area to the other area. These are all interneurons basically which are located at your central nervous system. Okay, this is the same thing which I told now. This is the same thing. Now what you have to understand is that myelin sheath, as I said that in the neuron, one of the important aspect is your myelin sheath. Now these myelin sheaths are basically formed by glial cells. There are two types of glial cells basically. One is called as Schwann cells and the other is called as oligodendroglial cells. Oligodendroglial cells. Now the peripheral neurons, basically when you talk about, say that in the auditory neuron, if I am talking about, what you have to understand is in the auditory neuron, the auditory neurons are myelinated by your Schwann cells, whereas at the neurons which are at higher levels such as cochlear nucleus, SOC, lateral lemniscus, or higher up, they all are myelinated by your oligodendroglial cells or your oligodendrocytes. Okay, so what happens is that, remember this one important point, all the peripheral neurons such as your auditory neuron is myelinated by Schwann cells, whereas neurons which are higher up at cochlear nucleus, SOC, LL, or IC, they all are myelinated by your oligodendroglial cells. Now if you want to understand that, if when I say that, at the auditory nerve is myelinated by Schwann cells, whereas the cochlear nucleus is myelinated by oligodendroglial cells, where the demarcation happens, what you have to understand is, if you look at ABR peaks, so you know that you have ABR peak 1, 2, 3, 4, and 5. So what you have to understand is that the ABR peaks, which are peak 1 and peak 2, are coming from your Schwann cells, whereas peak 3, 4, and 5 are coming from your oligodendroglial cells. Remember this, 3, 4, and 5 are coming from oligodendroglial cells, 1 and 2 are coming from your Schwann cells. Now what you have to understand is that, now most of the cases with retrocochlear pathology, particularly you have learnt about vestibular sonoma or auditory nerve sonoma, you would have learnt that wave 1 to 3 is prolonged. Wave 1 to 3 is prolonged means The tumor always arises at the junction between peak 2 and peak 3. That means to say that where where the myelin changes from Schwann cells to the oligodendroglial cells. Okay, the junction of the two, it is the site where the most of the proliferations will happen. Okay, so the tumors will arise from this area, which is also called as obstrainer redlich area, redlich, obstrainer redlich area. Okay, this is the junction of the two types of cells, that is your Schwann cells and the oligodendroglial cells. Okay, and the work of the myelin sheath is to conduct the action potential faster. Now why it is important is, understand, in the speech, when you look at a speech, you have small cues such as burst, your transitions, which are in few milliseconds. So when these are there in few milliseconds, it need to be coded at a faster rate. So if the timing is not there, that means to say that if the myelin sheath is suppose not there, these cues which are there, such as your burst or a transition or a VOT, a lead VOT, lag VOT, this will not get coded in the auditory neurons. Okay, so you have to understand that myelin sheath is there for faster conduction. That means to say that it is increasing the temporal aspect of a signal. Okay, and uh, what happens is that at the every gap, that is, I'll just go back to the picture of the neurons once again. So if you look at this picture, you can see that, you know, there is one myelin sheath, then there is some gap, then there is another myelin sheath, then there is some gap, then there is another myelin sheath, then there is gap. Now the gap where you can see, these are called as nodes of Renevers, and you have a specific ion channels which will work during when the signal is coming. That means say that when the neurons are getting hyperpolarized, these channels will get open, and then the signal will get conducted in the axon here. And what happens is that the signal will jump from one node of Renevers to the other node of Renevers to the other node of Renevers, and thus what happens is that there will be a faster conduction of the action potentials here. So this interrupt, here you can see that there is a gap. These are called as nodes of Renevers, and these are responsible for faster conduction of action potentials in the neurons, whether it is auditory neuron or whether it is whichever neuron it is. Now second thing which you have to understand is nothing but the myelin sheath acts as a insulator. When I say, suppose for example, you can think of, say that 10 electrical wires you have kept together and there is no insulator. That means say that there is no plastic cover over that. When there is no plastic cover over that, what will happen is the current of one electrical wire will go to the another electrical wire. The current of another electrical wire can go to another electrical wire. So you know that consequence, there will be a distortion of the signal, right? There will be a spark, which you say that a spark, it is nothing but it is a distortion of the signal. So suppose for example, if the auditory neurons, there are 30,000 auditory neurons which are there. Now what happens is that if there are 30,000 auditory neurons, if this myelin sheath is not there, then what will happen is the signal from low frequency will go to higher frequency, the signal will from higher frequency will go to the mid frequency will go to the higher frequency. So there will be a complete distortion of the auditory signal. Hence the myelin sheath is important for two things. One is to improve the temporal sensitivity, and second is it acts like an insulator, and uh, it acts like an insulator, and then what happens is that there is no signal leakage between the two neurons because of this one. Now another important thing which you have to understand is your internal auditory canal. Now internal auditory canal is nothing but, you have to understand, you have external auditory meatus and you have internal auditory meatus. Now internal auditory meatus is a small passage through which many of the neurons will come, and one of the neuron which will go or which will come from the brainstem to the cochlear nucleus, which typically goes, that is your auditory neuron, it goes via your nothing but your this canal basically. But this canal also has other nerves, such as for example, this has vestibular nerve. You can see that there is a superior vestibular nerve, inferior vestibular nerve, this is acoustic nerve, and this is your facial nerve which crosses from here. And here what you have to understand is that this is the area of your high frequency. in the acoustic nerve. Now, the importance of this canal is that suppose if there is a growing tumor from here, from the auditory neurons, then what will happen is if the tumor is big, it can suppress or compress the acoustic nerve. It can also compress the vestibular nerve. It can also compress the facial nerve. Okay, or if there is a tumor from the vestibular nerve, same thing will happen. It will compress the vestibular nerve, it will compress the facial nerve, it will also compress the acoustic nerve. Hence, what will happen is this canal is very important because the acoustic nerve is coming via the inner hair cells and reaching to the cochlear nucleus via this internal auditory canal. So if there is a growing tumor in the internal acoustic meatus from any of these neurons, eventually it is going to affect other neurons. Such as, for example, you would have learned that in retrocochlear pathologies or in patients who have vestibular sonomas, they have issues related to imbalance. They also have tinnitus and they also have a high frequency hearing loss. And later point of the time when the tumor really grows big and it is not operated, then there can be a Bell's palsy which comes from the compression of the facial nerve. That's why this is very important. This is the same picture just to show that where what is located. You have 2 kilohertz region here, 1 kilohertz region here, 6 kilohertz region here. So this is nothing but your human auditory meatus. Now, this is what you have to, another point which you have to understand about the auditory system. Now, you know that the cochlea is a coiled structure, something like this. Okay, it is 2.5 coil. Now, what happens is that there are some neurons which are connected here, there are some neurons which are connected here, there are some neurons which are connected here, there are some neurons which are connected here. So now, hence what happens is that from different portions of this cochlea, these neurons comes out. Hence, it appears that there is a rope. Okay, there is a rope like a structure. And this is, you know, that these are the basal structure and these are the apical structure. Hence, what happens is that the high frequency fibers will remain on the periphery. You can see that the high frequency fiber will remain on the periphery and the low frequency fiber will be in the center. That means to say that in the acoustic meatus, if there is a tumor which is arising from your vestibular nerve or the facial nerve or from the acoustic nerve, it will impact the high frequency fibers first and it will impact the low frequency fiber later. And that's why you see a high frequency hearing loss typically in patients who have tumor basically. This is another important thing which you have to understand, that is the blood supply to the inner ear. Blood supply to the inner ear. Now this is why it is important, is because it can affect the function of nothing but the auditory neurons also, indirectly or directly. Now this is your anterior inferior cerebellar artery, and from the anterior inferior cerebellar artery there is a branch which is called as labyrinthine artery, and this labyrinthine artery is supplied to both the cochlear structure as well as your nothing but as your the vestibular structure. Now suppose if there is a blockage of this artery here, somewhere here, what will happen is both the cochlear hair cells can die as well as the vestibular hair cells can die. Now what you have to understand, that suppose one inner hair cell is connected to 10 or 12 auditory neurons. One inner hair cell is connected to 10 or 12 auditory neurons. Now suppose if there is a blockage of this because of a moving emboli, okay, now what will happen is one inner hair cell dies, means the input to those 10 or 12 auditory neurons will stop. Fine. That means to say that those 10 or 12 auditory nerve which is connected to your cochlear nucleus, the input to cochlear nucleus will stop. Further, the cochlear nucleus cells are connected to your SOC cells. So what will happen is the input to those SOC cells will stop. Further on, it will go till auditory cortex. That means say that there is a death of inner hair cells in the cochlea, but the changes will happen till the auditory cortex level. These kind of changes which happens, these are indirect changes. There is no damage to the neuron, but only that input has reduced. These are called as transsynaptic degenerations. Transsynaptic degenerations. And later point, what will happen is if it does not receive the stimulus, it will stop functioning basically. So use it or waste it. That's all is the principle. So if you're not using it, it will get waste. That's why you call this phenomena indirectly, you call that as auditory deprivation, and you say that a speech identification scores are poor when there is an auditory deprivation. So this auditory deprivation is nothing but this is the way the process which takes place. Okay, so this blood supply is very important for this one. Now this is nothing but this is one row of inner hair cells and these are 3 or 4 rows of outer hair cells. And remember that nothing but all the afferent neurons, 95% of the afferent neurons which are going to the cochlear nucleus are connected to your inner hair cells. That means to say that the inner hair cells are very important. Then 5% of the afferent fibers are connected to your outer hair cells. Okay, and from the inner hair cells, each of the inner hair cells are connected to 10 or 12 neurons, and it leaves the cochlea via a small opening which is called as habenula perforata basically. And here if you look into this diagram, same thing, you have one row of inner hair cells, you have 3 or 4 rows of outer hair cells, and it leaves the cochlea via your habenula perforata. And this what you look at, it is nothing but a spiral ganglion. A spiral ganglion is nothing but it is the cell body of the auditory neurons, cell body of the auditory neurons. Here, there are two types of spiral ganglion cells. That means say that there are two types of auditory neurons, wherein one is called as type 1 auditory neurons and second one is your type 2 auditory neurons. Now, type 1 auditory neurons are myelinated neurons. Type 2 auditory neurons are unmyelinated neurons, non-myelinated neurons. Okay, these are not myelinated, whereas type 1 are myelinated neurons, and these are basically your bipolar neurons. Remember, type 1 are your bipolar neurons, myelinated neurons. Type 2 are unmyelinated neurons. But what is important is this is what now, this is your cochlea. Okay, and these auditory neurons are leaving from here. Now you can see that some neurons are leaving from the basal region, some neurons are leaving from the apical region. Now significance of this is that what you have to understand that the neurons which are connected to the apical region, lengthwise they are more longer compared to the neurons which are connected at the basal region. So the length, remember, the length of the neurons at the apical region is more compared to the neurons at the basal region. Okay, so this is the significance of this. This is what you have to remember. This I'm going to discuss little later that what is the significance of this. But you remember now the length of the neurons which is connected at the apical region is more compared to the one which is there at the basal region. Okay, the shortest neurons are there in between the two. That is the mid frequency fibers are the shortest fibers. Now, the spiral ganglion cells, the total number in humans are roughly, what you have to understand is roughly about 25,000 to 30,000 neurons which are there. Okay, and thickness is roughly 2 to 4 micrometer, and for type 1 and 0.5 micrometer for type 2, and length is roughly about 2 centimeter. In mouse there are 12,000 odd number of auditory nerve fibers, and in cats there are about 5,000 auditory nerve fibers. These are the numbers of a spiral ganglion cells. The auditory nerve which is there, it has got a diameter of 22 to 26 micrometer approximately. It is slightly longer in males compared to female because of the skull size. Typically the skull size of males are little bigger compared to the females, and hence it is slightly longer in males compared to females. 30,000 auditory nerve approximately, and as I discussed, type 1 and type 2 auditory nerve fibers which are there. Now, the auditory neurons, basically it can be classified now. Now, auditory neurons can be classified in many ways, which I'm going to discuss. Okay. Now, first is based on the spontaneous discharge. Now, based on the spontaneous discharge, what you have to understand is a spontaneous discharge means that there is no auditory signal to the system, that is the auditory system, but still there will be generation of some amount of action potentials in the neurons. Okay, because of which there will be some amount of activities which will be always going in the neuron. These activities are called as a spontaneous activities of the neurons. Now what will happen is whenever there will be a signal which will come which will come to the system, then it will depolarize the system, and when the system will auditory system will get depolarized, at that point of the time the firing or the action potential in the neuron is going to increase. Okay, so now understand with this diagram. Now the second diagram first, which you have to understand. Here you understand, you would have learned that this is your inner hair cell, this is your outer hair cell basically. Now what you have to understand in the inner hair cells and the outer hair cell is that typically the stereocilias are like this, in this pattern. That means to say that when there is no signal, they are oriented vertically here at the inner hair cell, at the outer hair cells. But whenever there is an arrival of the signal, what happens is that the shorter stereocilias are moving towards the taller stereocilias or the kinocilium. At that point of the time, there will be an action potential generated, and the amount of action potential will increase in the auditory neurons. Now whenever what will happen is the depolarization phase, there will be a hyperpolarization phase. Now in the hyperpolarization, what will happen is the taller stereocilias will move towards the shorter stereocilias, and hence there will be reduction in the firing here, or the action potential will reduce here. But normally what happens is that the stereocilias are like this. That means to say that not all the ion channels which are there connecting to these stereocilias are closed, nor all are open. That means to say that if it is not closed, then some amount of this one activity will keep happening in the hair cells, and that will lead to generation of some amount of action potential here, which is called as your spontaneous activity of the neuron. Now the depolarization in the neurons means that any activity which is above the spontaneous activity of the neuron is called as depolarization, and any activity which is below the spontaneous activity is called as hyperpolarization. Okay, now there are three types of based on the spontaneous discharge. That means to say that the one which you can see here, there are three types of auditory neurons. Okay, now one is called as low spontaneous rate fiber, wherein there are only one spike per second which will be generated. This is in the absence of auditory stimulus. Then there is medium spontaneous rate, which will be 1 to 20 spikes per second, and then there will be a high spontaneous rate which will be greater than 20 spikes per second. This is in the absence of the auditory stimulus. Now 16% of the total fibers are less than 1 spikes per second. 23% of the fibers, auditory neuron fibers, are 1 to 20 spikes per second, and 61% of the fibers are greater than 20 spikes per second. So this is your highest spontaneous rate fiber, and these are called as low spontaneous rate fibers. Now remember, low spontaneous rate fibers have high threshold, and high spontaneous rate fibers have low thresholds. Low thresholds means at a lower intensity itself, what will happen is there will be action potential generation in the neuron, whereas high threshold means you require a higher intensity to see some activity in these neurons above the spontaneous activity. Okay, so here this is a low spontaneous rate fiber. That means to say that unless and until you present 30 or 40 dB of a stimulus to the ear, these fibers are not going to respond, whereas these fibers can respond at 5 dB level or can respond at 10 dB level. Okay, so these are high spontaneous rate fiber, have low threshold. Low spontaneous rate fibers have high threshold. Now you have to understand that why these high spontaneous rate fibers and the low spontaneous rate fibers are there in the auditory system. Now this is your typical outer hair cells, and this is your typical inner hair cells. Now what you have to understand is outer hair cell is always standing vertically like this, whereas inner hair cell is tilted slightly like this. Now because it is tilted here, and as I said that there will be 10 to 12 neurons which will be connected here. So there are some neurons which are on this side, and there are some neurons which are on this side. Now if you go by the rule of gravity, okay, what will happen is if there is a release of ions here, which you can see in blue colors here, there will be more release of ion in these neurons compared to these neurons, because this is facing the gravity more compared to these neurons. So naturally what will happen is these neurons will be your high spontaneous rate fibers and these neurons will be your low spontaneous rate fibers. Okay, so remember, the neurons which are towards the outer hair cells, I am talking about position wise, towards the outer hair cells, they are high spontaneous rate fibers, and the one which is away from the outer hair cells, these are low spontaneous rate fiber. Okay, so remember one more thing, low spontaneous rate fibers have high threshold, high spontaneous rate fibers have low thresholds. Now what is the importance of this? Okay, now here you can see three neurons, one in red color, one in yellow color, and one in blue color. So remember, this red color is your high spontaneous rate fiber which has got low thresholds, and low spontaneous rate have got high thresholds. Okay, so now what you have to understand is, just one second. Okay, now see this. Now what is the effect here? Now here on the x-axis you have the intensity, and the y-axis you have a spike rate. A spike rate means the total amount of action potential which are generated. So here if you look into the high spontaneous rate fiber which have low threshold, it starts firing. That means to say that it has already the fiber which is 0 or 5 dB itself, it starts firing. Okay, already this has action potential, and then as you go on increasing the intensity, it reaches to a saturation level. Whereas a low spontaneous rate fiber, you require at least 40 dB of intensity. You look here, at least you require 40 dB of intensity to produce some action potential here. As you go on increasing the intensity, the amount of action potential is increasing here, and it is not reaching to a saturation, whereas the low spontaneous rate fiber and the mid spontaneous rate fibers are reaching to a saturation level. Now what is the importance you understand here? Now see, this arrow which you can see is the point of activation. That means to say that these are the threshold of the neurons. Okay, now this is your high spontaneous rate fiber and this is your low spontaneous rate fiber. Now what happens as you present the stimulus, the high spontaneous rate fiber will start firing here, whereas the low spontaneous rate fiber has not reached to the threshold here. As you go on increasing the intensity, what will happen is there are more and more of action potential here. Now the low spontaneous rate fiber has reached to the threshold. That means say that from here the neurons will start firing. Further, if you increase the intensity, the high spontaneous rate fiber has reached to a saturation level, whereas low spontaneous rate fibers continue to fire here. Now as you go on increasing the intensity, what will happen is this will reach to an adaptation stage, this will not reach to an adaptation stage. Now the importance of this is in intensity coding. That is, the high spontaneous rate fiber is responsible for coding of low intensity sound, whereas low spontaneous rate fibers are responsible for coding of high intensity sound. You will remember, high spontaneous rate fiber responsible for coding of low intensity sounds, and low spontaneous rate fibers are responsible for coding of high intensity sounds. Okay, now this is another important aspect which you have to understand. Now this you can see, this is called as a ribbon. Ribbon is nothing but this is called as a ribbon synapse. Basically this is there, the synapse between the inner hair cells and the auditory nerve is basically your ribbon synapse, wherein what happens is that the moment there is a signal, this what happens is that these are a small synaptic, this one, vesicles which gets combined to this ribbon. Now here what happens is that, understand this, now every neuron, as I said that in the previous slide, that there is a threshold, and at that threshold the neurons will start firing, whereas the ribbon synapse don't have any thresholds. It doesn't have any threshold. That means to say that as on the stimulus will come, what will happen is it will just release the signal. That means say that just release the neurotransmitters basically. So here what will happen is this ribbon synapse will basically help in improving the temporal aspect of the signal, because in the auditory nerve it is all or none phenomena, whereas the ribbon synapse does not have all or none phenomena. All or none phenomena means either the action potential is generated or the action potential is not generated. Means to say, here if you look at this arrow, if the stimulus which is coming is sufficient enough to reach to this threshold, it will fire. If it is not able to reach to this threshold, it will not fire. So either it is all or it is none. Whereas this one, it is not all or none. It is very simple. The moment there is a signal, it will release the neurotransmitters. So the ribbon synapse are important for improving the temporal aspect of the signal in the auditory neurons. This is very important. This is my favorite thing. This is the basilar membrane. Now, what is the basilar membrane? You would have visited to the circus. So you have a ringmaster. What the ringmaster will do? The ringmaster, on the tune of the ringmaster, all the animals will dance. So the entire auditory system dances on the tune of the basilar membrane. This is the ringmaster of the entire auditory system. Why? Understand this now. This is your basal region. This is your apical region. Basal region is narrower, apical region is wider. That's why the basal region is more stiff. The apical region is lesser stiff. The basal region is responsible for your high frequency. The apical region is responsible for your low frequency. That is not important. Important is what? That it is a resonator. It is a filter. Okay. Hence, whenever there is a low frequency sound, what happens that it gets processed from your apical region. Whenever there is a high frequency sound, it gets processed from the basal region. Fine. Now understand this, that in the next slide, this is your basal region and this is your apical region. So basal region are responsible for your high frequency, apical region are responsible for your low frequency. So when you learn about the tonotopic organization in the entire auditory system, you say that there are high frequency fibers, there are low frequency fibers, there are mid frequency fibers. Remember this, the auditory neurons don't have a tonotopic organization. The work of the auditory neuron is to pass the signal which is coming from the inner ear to the cochlear nucleus. That's all. Whatever the signal is, it is just processing that signal. So the neurons which are connected to the apical region will process the low frequency sound. The neurons which are connected to the basal region will process the high frequency sound. There is no logic behind that. The auditory neurons will have a tonotopic. No, the auditory neurons don't have a tonotopic organization on its own. The tonotopic organization in the entire auditory system is maintained by your basilar membrane. Entire this one is maintained by your basilar membrane. Remember that. Okay. Then you can ask a question that in the cochlear implant, when the cochlear implant is inserted, how this tonotopic, because it bypasses the cochlea and then it is directly stimulating the auditory neuron, then how this tonotopic organization is maintained. Remember, in the cochlear implant, it is a very crude method of assigning the tonotopic organization to the auditory neurons. Auditory neurons are meant to carry any electrical signal. That's it. So what happens is that the electrodes which are there towards the basal sides, they are assigned high frequency signal, and the electrodes which are assigned there towards the apical side, they are assigned a low frequency signal. That's all. Otherwise, nobody is sure, because what will happen is my basilar membrane can be 28 mm, your basilar membrane can be 29 mm, somebody else basilar membrane can be 30 mm, somebody else basilar membrane can be 32 mm. But what happens? The length of the cochlear electrode or the cochlear implant electrode remains the same for everybody. So where you have placed the electrode number 1 is at 4 kilohertz only, how you are sure? Nobody is sure, and there is no method to know it also. So assigning the tonotopic organization in the cochlear implant is just a very crude method. You just say that electrode number 1 is for high frequency, electrode number 20 is for the low frequency. That's all, nothing else. Okay, so this is the ringmaster. Now this is when you look into the internal auditory meatus, this is how the spiral ganglion cell looks in the internal auditory meatus. You can see that, and this is a case of auditory neuropathy. I just don't want to discuss auditory neuropathy. I just want you to understand that when I told you that if there is a pathology, that is the retrocochlear pathology in the internal auditory meatus, it will affect the acoustic nerve, it will affect the facial nerve, it will affect the vestibular nerve. It is going to compress that. Then there can be another neuropathology wherein there can be a demyelination of the neuron. Demyelination of the neuron. So whenever there is a demyelination of the neurons, the neurons will start disappearing, and hence in the auditory neuropathy, which is basically a demyelinating pathology, you can see that the number of spiral ganglion cells will disappear here. Now what is that you have to understand here in this slide is this. Now you have said that this is auditory nerve. There are 30,000 auditory neurons. So this is auditory nerve number 1, 2, 3, 4, 5, 6, 30 neurons. And this is your compound action potential. Compound action potential means what you record in your ABR, LLR is your compound action potential. You give a stimulus and whatever the potential you get combined from these 30,000 fibers, you get in your ABR. So this is the combined potential, which is your compound action potential. Now, if there is no neuropathology in the neurons, then what happens is that the fibers which are there, what will happen is they fire in synchrony. There is no difference in the this one firing of the neuron. Hence, when you get a compound action potential, what you will find, it will have a normal latency and it will have a large amplitude, which you can see here. Whereas there can be a demyelinating pathology. Demyelinating pathology means the myelin sheath is missing. The myelin sheath is missing in the neurons. Now suppose that the myelin sheath is missing by an equal amount in the neurons. Then what will happen is, as I said, myelin sheath is responsible for faster conduction of the action potential. So if there is a demyelinating pathology, there will be a delay in the signal. So timing will be affected. Hence, what will happen is, if all the neurons have equal amount of demyelination, then what will happen is action potential will be conducted, but it will be conducted with a slight delay. Hence, what will happen is the latency of this action, compound action potential, will be delayed, but the amplitude will remain same. Fine. But if there is a variable delay in the sense that, say that there are 30,000 neurons, out of that 10,000 have got demyelination, another 20,000 is normal. That means to say that some neurons will fire at its own time and some other neurons which are demyelinated will fire at its own time. And hence what will happen is, in the compound action potential, when you record, the amplitude will disappear. The amplitude will disappear here. So overall, what you have to understand is that if there is a demyelinating pathology, of variable delays, that means to say that some neurons have demyelination, some neurons don't have demyelination, then what will happen is the compound action potential will reduce. And hence, if you talk about the cochlear implantation in cases where you have demyelinating pathology, the benefit of the cochlear implants in this demyelinating pathologies will be less compared to a normal neurons which is there. And that's why in the first instance there will be a MRI scan done. MRI scan will be done to see that whether the neurons are connecting the cochlea to the cochlear nucleus or not, whether they are physically present there or not. Then this is your loss of a spiral ganglion neurons. That means say that the axons are missing. So when the axons are missing, there will be no conduction of the action potentials. Then there can be both demyelinating pathology and there can be a loss of a spiral ganglion cells. So these all will lead to these three, basically when you look into this, will lead to absence of the compound action potential. And hence if you are dealing with a case which has a demyelinating pathology, or you can say that person has a neuropathy, what will happen is the benefit with the cochlear implantation is going to be less. Okay. Now the demyelinating pathology, when you look into, it can have different kind of demyelination. This is a normal fiber where you can see that there are myelin sheath which are regular here. Then there can be a paranodal demyelination. Paranodal demyelination means, see, the small segment here has got demyelinated. Okay. Then there can be a segmental demyelination wherein the complete myelin sheath has disappeared here. In this, what will happen is the action potential is going to be normal, whereas in this, what will happen is there will be a delay in the action potential. Here also there will be a delay in the action potential. That is the thing, but the temporal aspect of the signal will be affected here. The temporal aspect of the auditory signal will be affected here. came back to the same thing. That is again this. Now, this is whenever there is a demyelinating pathology. What you have to understand is it affects the fibers which are longer first. Demyelinating pathology. That means to say that typically a person who has a demyelinating pathology will have a low frequency sensory neural hearing loss first, and high frequency fibers will get involved at a later point of time. And that's what you see in cases with auditory neuropathy. You have a patient with auditory neuropathy, typically what you will find is a low frequency sensory neural hearing loss. Again, the issue of Schwann cells versus glial cells, already I have discussed that wave 1 and 2 are coming from your Schwann cells, and wave 3, 4 and 5 are coming from your glial cells. But what is important with respect to the demyelinating pathology is that most of the time the demyelinating pathology starts from the Schwann cells. Is it clear? Whereas in the tumor, I have told you that the tumor starts at the junction of the Schwann cells and the oligodendroglial cells. Whereas here in the demyelinating pathology, always starts with the Schwann cells first. So when it starts with the Schwann cells first, what will happen is in cases with auditory neuropathy, what will happen is ABR will be absent from wave 1 itself. Will never see that ABR is getting absent only wave 5 or wave 4 in auditory neuropathy. It will be 1, 2, 3, 4, 5, everything getting absent. That suggests that the pathology is here. Okay, and in the auditory system, again, which you have to understand is that there can be a pathology at the dendrites, there can be a pathology at the axon, there can be a pathology at the cell body, and there can be a pathology which can be there at the terminal buttons. And we have no test which can rule out a pathology of dendrites from the axon, and axon from the cell body, and the cell body from your other part. A neuron needs to be normal in a structure and the physiology before you go ahead with the cochlear implant. So that's all for today. Thank you for your patience listening, and if you have any doubt, you can discuss. Shiva?
1 minute.
Hello, sir.
Yes.
Yeah, thank you so much for your detailed explanation, sir. Yeah. So any doubts you want to ask?
Sujit,
Yes.
thanks, man. Thank you so much for your wonderful talk. We'll see you again. Maybe next month. We need one more hour time.
Yes.
Okay.
Okay.
So we'll catch up again. It's almost like 8 now, I think.
Yeah, it's 8 now.
Thank you.
There are
Thank you.
no doubts?
Any doubts? All are hungry now. So
Okay.
It's detailed
Okay.
explanation, sir.
it's actually very nice,
Yeah.
man. It's very nice. It's almost like informative. Just listen to them. See.
Hi. Me and your Shiv Prasad sir are classmates.
Thank you, man. Thank you so
Yeah,
much.
thank you,
I'll
Shiva.
see you.
Okay. Yeah, okay.
Thank
Thank you.
you.
Bye.
Bye bye.
Bye.
Take care.